This is a 56-year-old hypertensive hypercholesteremic lifelong non-smoker who does have a family history of ischemic heart disease, who presented initially in 2011 with stable exertional chest discomfort that was initially treated by successful angioplasty to his chronically occluded LAD, the artery running down the front of the heart. And at that time the right coronary artery was patent, had just mild disease. He got full resolution of his symptoms at that stage, but has then re-presented earlier this year with further anginal symptoms. And further imaging has suggested that the right coronary artery has now occluded. An angiogram performed confirmed this, and he will have a further attempt at opening up the occluded right coronary artery today. If I show the images from the previous procedure, this was the modest disease in the right coronary artery and the occluded LAD. That's the artery that runs down the front of the heart, and this was successfully opened and a stent deployed such that when we looked at the images from earlier this year, the vessel was still patent, still open, with still good flow in that vessel, with no evidence of any re-narrowing of that vessel. You can see a different angiographic view, but this is now the artery that had the previous stent. This just light shadowing before the contrast enters the vessel is where the stent is, and the flow is now passing retrogradely, we call this, in the reverse direction to the blocked right coronary artery, so exactly the opposite of his previous presentation. And if I show you further images of the blocked right coronary artery, you can see the flow passing the reverse direction, and with images of both arteries being injected simultaneously. This is the flow. The vessel should have flow in this direction, but it's blocked in the proximal aspect of this vessel. The distal vessel, the terminal part of the vessel, is only being filled from flow from the contralateral injection. Patients that have totally blocked arteries are in a different category to patients who've got narrowed vessels. So totally blocked vessels are more complex in that the vessel needs approaching with different strategies. So this can either be with a wire being passed in the conventional manner from top to bottom, as it were, or in the reverse direction via these little small side branch septal collateral vessels. In this instance, I felt there was a reasonable attempt at repeating the procedure from top to bottom. A colleague has already tried this procedure. He's referred this patient on to myself as a specialist in this field, and I will have a further attempt in this manner. If I fail to pass from top to bottom, then I will try to pass a wire in the reverse direction and then meet with the wires in the middle and complete the procedure with conventional angioplasty and conventional stents. Success rate should still be relatively high. I think one would say 80 to 90% success rate, particularly as he has favourable collateral vessels, meaning these little channels that have opened up to supply the blocked vessel and keep that part of the heart muscle alive and healthy. That's why he's getting the anginal symptoms, because these little vessels aren't able to supply enough blood rapidly enough, particularly when people are exerting themselves in this situation. Colleagues send these patients to myself principally because these are long blockages. So a very short, discrete blockage. A non-occlusion specialist may make an attempt to open this up, and they may be very successful in the majority of cases. When the vessel is blocked over a very long segment, then these are specialist techniques that we utilise. It's rare that we don't make an attempt. There are certain situations where the vessel, perhaps beyond the occlusion, is very small and looks very unhealthy and very unattractive. But with these new modern techniques, even really quite diseased vessels can be treated quite successfully in the majority of cases. And what guides us is the healthiness of the distal vessel. That means that the sort of the terminal part of the vessel, and also whether we have these fine collateral vessels to help us achieve a route in the opposite direction. So as long as there's good collateral vessels, with modern techniques we can actually open up a lot of these blockages. And I would say it's an 80% success rate in general. There are some controversies in this area of when we offer this service, but usually patients will present with symptoms. If their symptoms have settled, this becomes a little bit more problematic, but in general, if on scanning there's evidence of a large part of the heart muscle being at risk, then there is some justification for performing an angioplasty procedure. Having said that, one discusses this with the patient because the risks are a little bit higher. And in general, I prefer that my patients are symptomatic. If they have a very large area of heart muscle at risk, then I will have a discussion with the patient as to the appropriateness of the procedure and what I believe their individual risk would be for the procedure.